Color Doppler, the rule in the books is that a polyp contains a single vessel and fibroids contain multiple vessels. This is true most of the time, but there are a lot of exceptions, so it's not pathognomonic and you can't use it reliably. If you have 3D, by all means use it. So here's an example of a couple polyps there. In reality, I think cine mode is just as good, but if you have the 3D, it's great to use. And here's just an example of a pre-3D getting the C-plane there. So which of these 4 patients has a malignant cause for postmenopausal bleeding? And we see bumps in all of them, but this turns out to be retained products of conception from MJ's article. Here's a bunch of polyps. Here is a fibroid, and this is the endometrial cancer right here. So we're pretty good at making path diagnosis, but not good enough. So in terms of pathology, we'll start with endometrial polyps. They're typically homogeneous, hyperechoic with a narrow base. They account for about 30% of postmenopausal bleeding. And what you want to do is tell your gynecologist how many they are, where they are, what the base of attachment is. So we have longitudinal and coronal planes and multiple polyps. And again, we can't make histodiagnosis. This looks like a polyp here. It's great. It's homogeneous. It's hyperechoic. But when it was whacked out in the top right corner, there was a small focus of grade 1 adenocarcinoma. Here's just another example, and hopefully I'd call that on EV, but you wonder if you'd pass by it. But here it is on the SIS. Here's another example. Here's an obvious polyp here. But then what's this hiding behind the balloon? So remember, you always have to deflate the balloon, and here you can see the solitary feeding stalk of a second polyp. Fibroids are really, really, really common. The bottom line on these is you want to figure out whether it's more half in or half out. If it's more than half in, you can do a good job removing it hysteroscopically, but if it's more than half in the myometrium, you end up needing to go to a myomectomy. So that's the information we want to give our GYN docs. So here's just a classic appearance of a fibroid. You have this cap of endometrium on top, the fibroid here, and obviously both of these from MJ's article are projecting into the cavity and can be removed hysteroscopically. Here's one, would you call that transvaginally? Might be tough, but with the SIS, it's really easy to call, and you get a sense of how much of it is sticking in the cavity, and here you see multiple blood vessels in it. Here's another one right here, and again, it's pretty easy to see that most of this is sticking in the endometrial cavity, so it can be removed hysteroscopically. Here's another one right here, classic appearance, multiple blood vessels, and you can see it nicely outlined by that thin cap of endometrium. Hyperplasia makes up about 6% of postmenopausal bleeding, and there's a spectrum from simple hyperplasia without atypia all the way up to severe atypia, basically on the road to cancer right there. Same risk factors as cancer. So here you can see this irregular appearance here. This turned out to be simple hyperplasia. Here you can see something that looks like a polyp, but there was complex hyperplasia without atypia within it. Here you can see this plaque, and this turned out to be mild atypia. And then the reason we're doing this whole talk is endometrial cancer. As we said before, it's the 4th most common cancer. It's typically broad and large, as we see right here. So which of these is not endometrial cancer? We're going to come back to this in a couple minutes, but I'm giving you 4 examples of abnormalities in the endometrium. So here's just a classic example, big lobulated mass, exophytic, projecting into the cavity. Here's another cancer from PC. Here we had a cervical stenosis or occlusion with a malignant hematometros. You can see that there. Here's another one from MJ's article, very irregular, lobulated, maybe invading into the myometrium. You can see these look the same. And the key thing to remember here is that endometrial cancer can be very serous and very infiltrative. So if you're not getting good distension of the cavity, worry that you have an infiltrative endometrial cancer there. Your odds ratio is around 7 or 8 with poor distension. And here's an experiment we did where obviously this patient was not complaining of pain when we were infusing fluid in, clamped both fallopian tubes, got a great seal at the cervix, and pushing really, really hard, I could barely distend the endometrial cavity right there, and this was an infiltrating endometrial cancer. Here's one, looks great for a polyp, has a single blood vessel like a polyp, but at surgery, the bottom right corner of this had a tiny focus of papillary serous carcinoma. So again, focal masses are surgical masses. Then you look at this one, lobulated, hyperechoic, irregular. This is a classic appearance for endometrial cancer. Turned out to be breast cancer metastatic to the endometrium. So we can't make path diagnoses. So which one of these is not endometrial cancer? And you can see multiple varieties right there. But these top two turned out to be cancer. This was cancer in a polyp, and this was breast cancer metastatic to the uterus. Can you use SIS and tamoxifen? Some people say yes, but the bulk of the majority says the endometrium is always going to look abnormal in patients on tamoxifen. So talking to my gynec friends, basically they don't recommend imaging, whether transvaginal or SIS, anybody on tamoxifen, because it's always going to look abnormal. You just wait till they bleed, and then you treat them at that point in time. You can use SIS to evaluate infertility. Here's a malaria infusion abnormality seen on SIS. Here's an example of Asherman syndrome following DNC. We had multiple adhesions, bringing the uterus down. We can look at tubal anatomy. We said that the only reason we're doing HSGs now is really to look for tubal fill and spill. Well, you can use ultrasound contrast agents, as you see in this video clip right here, and determine whether the tube is open or not. And we're obviously not going to get nearly as pretty pictures as we do with a conventional hysterosalpingogram, but if all we care about is the tube open and spilling, this is good enough, and we get a much better look at the endometrium with SIS. You can use fancy ultrasound contrast agents, or you can just grab some room air, put it in a 20 cc syringe, and slam that in. In terms of intervention right here, bottom line, a couple people are working on this. This is from a friend of mine, and he's very talented, and he's got these Rube Goldberg type contraptions, but it's not ready for prime time. So basically, if you see a polyp, then you need to go to hysteroscopy. How does SIS compare to other standards? It's as good as diagnostic hysteroscopy under general anesthesia at detecting focal lesions, and it's better tolerated than an office hysteroscopy there. Another quote, you can avoid 2 out of 3 hysteroscopies. It's a lot safer, cheaper, quicker for the patient. SIS is better tolerated, requires less intervention, provides significant cost savings when compared to office hysteroscopy. So to sum up, we talked about why we worry, terminology and technique, what's abnormal in a variety of scenarios, abnormalities seen on transvaginal ultrasound, other diagnostic modalities like DNC, endometrial biopsy, hysteroscopy. Then we had a talk within a talk on saline infusion sonohysterography, divided into overview, how to do it, and then examples of multiple different pathology. Remember, technique matters. Despite Tom Cruise buying his own ultrasound machine there, it really helps to know what you're doing there. So know how to measure it. Remember that under 5 millimeters reliably excludes endometrial cancer. Over 11 millimeters in asymptomatic postmenopausal women, not hard data, but most people would say biopsy at that point. And remember that SIS is easy to perform, works for all of us who are average, has a short learning curve, and is a really, really good test. And I want to thank all of these people for slides and pictures. Thank you.